Hi, everyone. Happy Tuesday. Thank you all for joining us for another session of TP Recap. Today, we have three outstanding Academy members, Simi, Glenn, and Nicola, who have put together some impressive teaching points for us and presentations. So I'm looking forward for their session and for all the teaching that they have prepared for us. And just to remind you all that this is an interactive session. And before we start, Glenn, would you like to introduce yourself and then start your presentation?
Okay, good morning, good afternoon, good evening, everyone, wherever you are. My name is Glenn. I'm a medical student in Botswana, Southern Africa. So, I'm one of the CP Solvers members. So, I saw a case on the 22nd of May, and I'll be doing the teaching points recap for that. So, with that, I can then share my screen. Give me a second. Okay. Uh, Okay. I'll be doing the teaching points recap for bilateral leg edema. This is a case that was presented on the May 22nd by Prashant. The case decedent was Rabi and Julia. Um, so Starting off with the causes of the bilateral leg swelling before getting onto the case. So we can classify the causes of bilateral leg swelling according to the mechanism that causes bilateral leg swelling. So here I try to mention the ones that are relevant. So you can classify according to increased plasma volume due to renal sodium retention. This will be causes such as the most common ones, heart failure, renal disease, and some drugs. Actually, there are a lot of drugs that can cause this, but at least the ones that most commonly does this are the calcium channel blockers, the NSAIDs, and some endocrine drugs as well. Also, early cirrhosis can do this as well. Um, Another thing to consider will be the venous obstruction and the insufficiency. This is seen in things like cirrhosis, hepatic venous obstruction, acute pulmonary edema, and venous thrombosis. The others that you can think of are inflammation due to increasing capillary permeability, low albumin, and lymphatic obstruction. As you can see, this will be like what we'll be thinking about for the cases, the case of bilateral leg swelling. Okay, now for the problem presentation, so we had a 89-year-old female who presented with progressive shortness of breath, bilateral leg swelling. It's a known heart failure patient. Um, Also aortic stenosis post HAVA 4 months. However, didn't have cough, PND, and history. Past medical history was suggestive of diabetes, hypertension, hyperlipidemia, GI bleed, and pneumonia. These are the following medication that the patient was taking. One exam was hypertensive, was hypoxemic, had pale conjunctiva, and had bilateral leg edema, which I mentioned some of the differentials that for the labs, there's some notable anemia from the baseline of 9 to 10, also elevated creatinine of 2.65, and other causes. Other findings of urinalysis showed 2 plus protein and 3 plus hemoglobin. So from here, anyone can type in the chat and just to just from this problem precision that I just mentioned here, just few causes that can that will be the most likely um, um, differentials here, looking at these causes that I mentioned here. Let me move on. So from the case that I presented, because of the hematuria and the proteinuria, um, uh, we thought of glomerulonephritis is the most likely differential in this case. Instead of just heart failure exacerbation, because there was no cough and no PND. So the causes of glomerulonephritis, you can classify them into three brackets. So we have the post-immune causes. These are the causes that when you look into immunofluorescence, they don't light up. Actually, I will talk about this one further in the next slides, but this associated with the encavanculitis. Uh, Also, the most common causes are the immunocomplex depositions, the granular deposits. Majority of the causes are here. This forms the granular deposits in immunofluorescence, and then the unique one, the anti-GBM disease, forms linear deposits. Actually, the only one in this bracket. So now, going over the glomerulonephritis schema of the clinical problem solvers. So just like I mentioned, the three brackets: post-immune, immune complex, and anti-GBM disease, which is kind of unique. The only one that has presents in immunofluorescence with linear deposits, and um, from here, this one, the clue for getting the diagnosis right will be hematuria, and then hemoptysis, as well as the anti-GBM disease also affects the collagen in the lungs as well. For the post-immune causes, so we think of the ANCA vasculitis causes. So um, the eosinophilic and then granulomatous polyangiitis all fit in here. And then the big bracket, the immune complex one, we classify into normal complement and the low complement. Or the normal complement, the causes can be IgA nephropathy. This is usually 2 days, 1 to 2 days post a respiratory or GI illness, and can complicate with inaction, like purpura, where the patient can have some lesions, purpuric lesions after um, the 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 respiratory or gastrointestinal infection. And then the low complements, you can classify them by either infection, autoimmune, and cancer. I'm going to start with cancer. For lymphoma, is usually related to cryoglobulinemia. Actually, the other three causes that can lead to in these causes that can lead to cryoglobulinemia that can then present with glomerulonephritis. And then you can have Sjogren and HCV infection as well. For the autoimmune causes, you think for the common ones, so the common one will be SLE, there will be positive NCAS, positive dsDNA and all that. For the rare ones, you have Sjogren and all that. And then for infectious causes, we classify into chronic and resolved. For the resolved one is post-apical glomerulonephritis, and this one presents few weeks after the strep infection, either the pharyngitis infection or the skin infection caused by strep. And then for the chronic ones, I've classified into viral and bacterial. Actually, HCV will be the most common cause, and it's also related to cryoglobulinemia. And actually, cryoglobulinemia can also cause membranoproliferative glomerulonephritis. And then you also have HPV, HIV as well. Some bacterial causes here can also cause um, glomerulonephritis. So from this causes, for our patient, we can think of some conditions can then rule out SLE because of the patient is 98 years old. We can have some differentials like lymphoma because the age is around the 90s, and then post-rep didn't have any upper respiratory infection. He just had a history of pneumonia, and then this ones you can also rule out IgA. And then you can have other differentials such as endocarditis as well, in the causes because of the past medical history, and also um, these other causes are also um, possible in this case. So and also not forgetting the mimics. So for the mimics that of glomerulonephritis can also have anticoagulation nephropathy, focal segmental glomerulonephritis, and Alport disease. So from here, I will now be moving on to the rest of the problem presentation. Just Oh. So for the rest of the problem presentation, so during microscopy, it confirmed the glomerulonephritis with the dysmorphic red blood cells. The don't fire our urine protein was 969. That's low complement, which means from the schema that I had, we can consider only these causes, and then we also had positive rheumatoid factor. And the echo ruled out endocarditis, which means endocarditis is no longer in our differentials. And also the SPEP mentioned confirmed monoclonal M spike with IgM kappa. So the final diagnosis was then cryoglobulinic glomerulonephritis. There was some deposition of the cryoglobulins in the glomerular basement membrane, which means our causes can either be related to HCV, Sjögren, which will be less likely, and lymphoma. So moving forward, so I put a slide on the membranoproliferative glomerulonephritis, which can be caused by cryoglobulinemia, which was present on the patient. So we can classify the causes of membranoproliferative glomerulonephritis into two causes: the type 1, the immunoglobulin mediated, and the death deposit disease, which is rare. So for the type 1, which is kind of related to our patient here, it's actually can occur as a primary disease in children. In adults, usually related to ACV, SLE, cryoglobulinemia that we mentioned, lymphoma, and monoclonal gammopathy of unknown significance. And the pathophysiology is that these complexes, immunoglobulin complexes, they activate the classical pathway, unlike in the dense deposit disease where the alternative pathway is get activated, but most of them will lead to low complement. And this one is mostly seen in children and usually occurs secondary to a trigger. So with all what I've mentioned, I came to a key point of this case is that when you evaluate a bilateral leg swelling in a non-hepatitis patient, not presenting with typical heart failure signs, just consider the differentials. Like in this case, the patient didn't have cough, jugular venous detention. So you can do further workup. And for this patient, we're fortunate that they were able to find the signs of glomerulonephritis, and from there, further workup showed cryoglobulinemic glomerulonephritis. So with that, thank you all for listening. These are my references, and with that, I'll stop sharing the.
Thank you so much, Glenn. This is such a great presentation. And this is not an easy case, so kudos to you for being able to present it and teach us. So thank you again. And now moving next to Simi. Simi, would you like to introduce yourself and start with your presentation?
Hello, everyone. Thank you so much for joining. And Glenn, it was such a detailed presentation on glomerulonephritis, and we got to learn a lot. And I'll just start sharing my screen today. I'll do the recap of a case that was presented initially by Ethan, and I'll try to do a good recap for you. So the case we have is Beyond the Cuff, Unveiling a Mediastinal Mystery. And it was presented by Ethan, and discussants were Dr. Ravi and Mariana. And I'll do the recap of this case. And let's get started. So the initial presentation in this patient was a 36-year-old male with 2 weeks of progressive cough and intermittent fever. So what are your top differentials for subacute cough? A, upper respiratory tract infection, B, post-viral cough, C, pneumonia, D, GERD, and E, something else. Does anyone want to share in the chat or wants to unmute and share about what you're thinking of top differentials in someone with subacute cough? So whenever a person has subacute cough, with all this limited information, I think there is no right or wrong answer at this moment. And everything we can consider about broad differential, we can think all these options as well as many other options at this point. Saucin mentioned A or C. Yes, as I said, we can just have a very broad differential at this moment, and we can learn as we move along this case that what more information we have. And there is someone Abru mentioned AC or E. Yes, so I think they're all great ideas. And whenever we have cough, we can always look for red flags in benign seeming cough. And or when patient has weight loss or persistent fevers, or when there is blood in sputum, and we can always look for associated symptoms. So let's see what associated symptom our patient had. So as the case unfolds, this patient had a past medical history of smoking, and vitals in this case were normal, and there was no fever, no hypoxia, and exam showed only jugular venous distension. And so what stands out here? Obviously, what I haven't read stands out here. So jugular venous distension was the associated sign with cough. And Dr. Yamke mentioned about medicine-induced ACE inhibitor-induced cough. Yes, that's a great point too. But in this patient, the medications, there was no ACE inhibitor, and there was no fever as well. And so the next question is that when a person has JVD and cough simultaneously, how can we link these two? Would anyone like to mention in the chat and perhaps unmute or share that what can we think of when we have JVD and cough simultaneously? Yes, there are great thoughts in the chat about heart cause or obstruction, and Rahul said intrathoracic hypertension. Alina said elevation of cup receptors. Are you guys in a place to unmute and share? If not, that's fine too. Rahul and Alina, are you able to unmute? Also, Abru, you mentioned a great thought. Would you guys like to unmute?
Hi, Phoebe. Can you hear me? Yeah.
Yeah.
So I was thinking, basically the patient is having cough and now this subacute history along with the jugular venous distension. I always wonder when I'm seeing jugular venous distension, either is it because from the pressure issue or volume issue, like patients with like volume issue like congestive heart failure, or pressure issue like pneumothorax, or some kind of right heart failure secondary to the pulmonary embolism, or neither of issue like cardiac tamponade, and all this physiology would compress the mediastinal vessels, and that could present as jugular venous distension on physical exam. But in this case, cough can be seen in CHF, and it's also seen with any mediastinal masses. Or honestly, I really don't think so about pulmonary embolism, and pneumothorax usually present as acute manifestations. So to narrow my DDX, is a seen in congestive heart failure, and also any kind of some kind of mediastinal issues which is raising the pressure that could present as jugular venous distension. At the same time, it's going to irritate the bronchioles, all the airway tracts, irritation of the cough receptors, and maybe present as subacute history of cough. Yeah. Thank you.
Thank you, Rahul. That was great and some amazing thoughts. And it was great how you narrowed our differential. And I see interesting comment by Matthews in the chat as well. Are you in a place to unmute and share? If not, that's completely fine too.
Yeah, I can unmute. Yes. So thinking about some of the etiologies that could cause this JVD and also cough, maybe some pulmonary pathology, some exacerbated COPD. And thinking more chronically, yes, you could think that it would cause a cor pulmonale and cause this JVD with a subacute presentation. Maybe the nerve irritation or mediastinal masses could be something more to be considered.
Yes, thank you so much. Those were amazing thoughts, and definitely we can think about core pulmonary here. And so now I'll just share a brief schema of the structural approach that when we have JVT and cuff together, we can think about a structure-wise approach where we can think about mediastinum, heart, diaphragm, and also about lung and pleura. So in the mediastinum, we can think about masses or about superior vena cava syndrome, because what happens in mediastinum masses that these masses compress on the jugular vein and can cause jugular venous distension, can irritate surrounding structures, can also cause cough. And as per the heart, we can consider myocardium, endocardium, and pericardium. And anything going wrong at these structures can present with JVT and cough. In myocardium, we can have cardiomyopathy or MI, and there can be either a filling defect or a pump dysfunction, which will cause backup of blood, resulting in JVT and cough. And in endocardium, we can think about heart failure or valve issues. And for pericardium, we can think about constrictive pericarditis, cardiac tamponade, and we know that diaphragm plays a very important role in our body, and diaphragm paralysis or elevated hemidiaphragm can also cause JVT and cough. And as for lung and pleura, we can think about COPD, and just like Rahul mentioned about pulmonary embolism, because it acts as causing obstruction and then causing JVT, and also with core pulmonary, just like Matthews mentioned. So now, to summarize, we have a 36-year-old man with intermittent fevers, and at this time, the fever was not present. He has progressive cough and with GVT. And then the next step was to get an X-ray, and we got this X-ray. Would anyone like to unmute or share in the chat that what does this X-ray show and what is concerning in this X-ray at this point? Yes, Austin, you're completely right. Also, Lucas, would you like to unmute and share more with us after about the left mediastinal mass that you shared? Okay, that's fine too if you cannot unmute, but thank you so much for sharing with us. And so once we have this X-ray, what do you think is the next step? What else imaging-wise would you want in this patient? So the next step in this patient was CT, as everyone mentioned in the chat as well. So this X-ray showed presence of mediastinal whitening, and then a CT confirmed the presence of an interior mediastinal mass. So what can cause a mediastinal mass in a 36-year-old male? So what do you guys think can cause this? So yes, Lucas mentioned about 40s. Yes, that's one point. Would anyone else want to unmute and share something? So I have this schema showing the approach to mediastinal mass. So first of all, we think about the 4Ts. And these 4 terrible Ts include thymoma and teratoma, terrible lymphoma, thyroid, as well as parathyroid. And this is for anterior mediastinal masses. And this patient had an interior mediastinal mass. But let's also talk about middle mediastinal masses and posterior mediastinal masses. So in the middle mediastinum here, we can see esophagus, we can see some vascular structures. So we can have benign cystic tumors in the middle mediastinum, vascular abnormalities, and esophagus is present, so esophageal masses can be present. And as for the posterior mediastinum, we can think of something close to the spinal cord, because we have spinal cord in the posterior, and so we can think about neurogenic tumors, nerve sheath tumors, any sympathetic or parasympathetic tumors. So these are the key things that are worth considering. So the next step in this case was to get tumor markers, because we had this anterior mediastinal mass and we were thinking about these terrible Ts, and these are really terrible. So we had to think about getting the tumor markers in this patient. And would anyone like to unmute and share that what tumor markers can be linked to what tumor? AFP, beta HCG, and CE were the tumor markers which were initially obtained. So can anyone share what these tumor markers can be linked to? So So here we found that tumor markers really matter, and the AFP is elevated in hepatocellular carcinoma as well as yolk sac tumor. Beta-HCG is elevated in choriocarcinoma as well as testicular tumors such as non-seminimatous tumors. And CEA is found to be elevated in pancreatic, breast, colorectal, and gastric tumors. And in this patient, we had elevated AFP level. The rest of tumor markers were normal. And then the next step was to get the biopsy of the mass. And AFP was found to be elevated. And then pathology confirmed the presence of mediastinal mass, secondary to yolk sac tumor. And PET scan also confirmed the presence of this tumor. So that was the case for today. And just to summarize, we had a 36-year-old man who presented with progressive cough with JVD, and we found an interior mediastinal mass. And AFP was also found to be elevated. And then biopsy confirmed the presence of yolk sac tumor. And there are a few take-home points here. So when we have subacute cough, it always requires a second look for systemic signs. And in anterior mediastinal masses, we can think about forties, thymomat, teratomat, terrible lymphoma, and thyroid. And tumor markers do matter. And we can get the final diagnosis by connecting labs, imaging, and pathology. And thank you so much, everyone, for joining. And I hope you guys got to learn a little from this recap.
Such an awesome presentation, Simi. It was very engaging. Thank you so much. And moving to our last presenter, we have Nicola. Would you like to introduce yourself and start your presentation?
Hello, my dear friends. My name is Nicola. I'm a recent medical graduate from the small but very beautiful country of Croatia, if I may say so myself. I'm currently pursuing my PhD on the topic of cancer-associated thrombosis at the Medical University of Vienna. And I have brought for you a case. I think May was just a second. Can you see my screen? All right.
Yes.
Great. So I wanted to say May was just such an awesome month at the Clinical Problem Solvers. There's been so many amazing cases, many pearls, many things to learn. And I have brought for you one particular case, which I really liked, and I hope you're going to like as well, which was presented by none other than Zachariah G. and was beautifully and artfully discussed by Vijay and Rabi. So let's dive straight in. So we have a young woman. She presents with 4 key findings. She has a painful rash on her chest, an acute onset headache, a history of venous thromboembolism, and she's found to have several lab abnormalities. So let's just tackle these one by one. When somebody has a rash that hurts, this should definitely raise a red flag. A painful dark rash often means necrosis, and necrosis of the skin typically arises through 2 major pathways. Either we have ischemia, a vascular supply issue, or we have severe inflammation like vasculitis or an infectious process. To distinguish these two, we can focus on clinical markers of inflammation. So we can look for fever, we can look for an elevation in the CRP, in the erythrocyte sedimentation rate, leukocytosis. These all suggest inflammation. The absence of such findings, such as in this particular patient, steer us toward ischemia as the main cause. So what's differential for ischemic skin necrosis? There's 3 medications that we have to look out for: warfarin, heparin, and levamisole. All of these can cause skin necrosis. There's also cold-induced injuries such as chilblain or frostbites, embolic and thrombotic causes as well. So now let's revisit her history of a venous thromboembolism. So first of all, every time we hear about the previous deep vein thrombosis or a pulmonary embolism, we must always ask ourselves, first of all, is this a provoked event or is this an unprovoked event? Or are we on the fence? And this matters because of two reasons. It's going to impact the duration of anticoagulation, so it's going to impact treatment, and it's also going to impact the further workup that we need to perform in this patient. So we can look for an provoking factor, an obvious provoking factor, such as a patient who has had a recent major surgery, a major trauma, someone who has a current active cancer diagnosis or a prolonged immobilization period. But as you can see on this small table, some risk factors are just not as strong as other risk factors. So what about potentially a patient who has a DVT after a 2-hour flight? What about the DVT after a minor laparoscopic surgery? These are tricky questions where you should consult your local hematologist, thrombosis specialist. But to keep these things simple, generally, if we are unsure, we treat the VTE indefinitely, as we can never be sure that this provoking risk factor is actually gone. If it is a sure, strong provoked risk factor for the VTE, we can treat it for a duration of 3 to 6 months and then be sure that the risk of recurrence is gone if the provoking factor is also gone. In young patients with unprovoked VTE, we have to consider working up on thrombophilias. And the reason is not really because of the patients, but because of her family relatives, for which this also might be an important factor. In patients who are older, so over the age of 50, an unprovoked DVT should definitely trigger age-appropriate cancer screening. So when we talked to this patient, we found out that she had unprovoked deep vein thrombosis and was put on indefinite anticoagulation. So while keeping this in mind, let's go further to evaluate acute headache. So when evaluating again a patient with a new or atypical headache, such as this one, because it's an acute onset sudden headache, it can be helpful to organize potential secondary causes by just the rough anatomic region so that we don't miss out on anything. So it can be intracranial, such as the meninges, the brain, or the blood vessels, which can be affected, both arterial and venous. It can be a head and neck process. So it doesn't have to be sort of in intracranial process always. So it can be the eyes, the ears, the nose, the sinuses. It can be the jaw, the teeth, the neck, or there might be just a systemic cause with the headache as a sort of a bystander. So in this patient, we got a CT head scan, and we actually found a cerebral vein thrombosis as the cause of this particular headache. And finally, let's tackle the fourth sort of major discussion point, which is the lab findings, which I sort of insinuated that they were abnormal. So we found, first of all, a low hemoglobin level. We found low platelets. And we found a prolonged PTT, which did not correct by a mixing study. So maybe anyone can unmute and comment briefly on what is sort of the first thing that comes to mind when we see a low hemoglobin and low platelets in a patient who's not coming from a travel from Africa, let's say. Sausan wrote it in the chat. So we might be considering a MAHA, thrombotic microangiopathy. As for the prolonged PTT, which does not correct with a mixing study, and I have a very simple schema here of the mixing study. So basically, we take the patient's plasma and we add to it a healthy plasma. And if the prolonged PTT is due to a loss of a factor, it's going to be corrected by the addition of healthy plasma. If it does not correct, it implies that there's an inhibitor in the patient's plasma, which is now also inhibiting the healthy factor added by the healthy plasma. And there's two things, or actually three things to consider here. We might have an inhibitor against the factor. We might have an inhibitor against phospholipids, or we might have contamination with heparin. So let's quickly now think again about this whole case. So we have a young woman. She presents with a painful dark rash, which we discussed is probably of ischemic cause. We have found now an acute cerebral sinus vein thrombosis. Keep in mind, this is a patient who is on anticoagulation and she's still developing a VTE. She has a history of an unprovoked DVT and she has a presumed MAHA or thrombotic microangiopathy. Now, is there anyone who might have some differentials or a definite diagnosis or ideas? And Marie is right on point. And are you in a place where you can unmute and maybe just comment on why you think this might be? If not, then I'll just move forward with some labs that were then performed, and the patient had lupus antibodies, anti-cardiolipin antibodies, and anti-beta-2 GPI antibodies, which, like Anne-Marie wrote in the chat, brings us to the diagnosis of an antiphospholipid syndrome. So let me just briefly give you an illness script for antiphospholipid syndrome. Basically, you can think of APS as an autoimmune thrombotic disorder. Its prevalence is 50 in 100,000, so it's a quite rare diagnosis to be made, but it can be definitely a detrimental one. The risk factors are female sex, young age, usually below the age of 40, and a history of any autoimmune disease, but especially, of course, SLE. The diagnosis or the suspicion arises from an acute unprovoked VTE, but also arterial thromboembolism, ATE. Recurrent miscarriage is another sort of classic presentation, and a skin necrosis, a rash, which is known as erythema retiforme. On labs, you confirm the diagnosis by looking at the antibodies. There's 3 of those, which have to be positive over a longer period of time, usually at least 3 months. So you need to get two of those at least to really then take home the diagnosis of antiphospholipid syndrome. And what we do in these patients, we treat them long-term with a vitamin K antagonist, and I think this is also a management pearl. You really should put patients with antiphospholipid syndrome on a VKA rather than heparins and NOACs, which we do like more sort of in treatment setting, but we know from prior studies that vitamin K antagonists are still the best options here. And with that, maybe just to ask you again a question to all of you, my friends, because this was a question that I asked myself then when I, at the end of this case, is where does antiphospholipid occur in your differentials, in your schemas? What sort of symptoms or lab features, or when do you think about antiphospholipid syndrome? Maybe anybody has thoughts? Elena mentions ultra hypercoagulability. Would you mind unmuting maybe, Elena? What exactly do you mean by ultra hypercoagulability?
Yeah, I think it's what Sawson said. So clotting pretty much everywhere. So in the arterial system, in the venous system. And then I think the overlap of really thrombotic occlusion in very big but also very small vessels, as we could see in this case. These are very narrow diagnosis and pretty much boils down to APLS, sometimes TDP.
You're absolutely right, as always, my friend. Let me just share my final slide with you all. So these were sort of my things where I include antiphospholipid syndrome as a differential. So definitely in a case of an unprovoked venous thromboembolism, especially in the right patient, so a young female patient who might be having repeated miscarriage, but actually not just an unprovoked VTE, but also an unprovoked ATE. So a young patient with a stroke is definitely something to where antiphospholipid syndrome should be worked out. Then some more sort of esoteric presentations, but a patient which present with a concomitant arterial thromboembolism and venous thromboembolism. I think about TAP, so I think about TMAs, I think about antiphospholipid syndrome, I think about paroxysmal nocturnal hemoglobinuria, and potentially a DVT with a patent foramen ovale. I can cause a patient to sort of present with both of these at the same time. There's also this sort of breakthrough VTE, which just means a patient who is presumably on anticoagulation and then still develops a venous thromboembolism. So 9 times out of 10, the issue is going to be the anticoagulation itself. So the patient is either not adherent, maybe forgot about taking his medication, maybe there's a resorption problem, so maybe he has malabsorption. Obesity can be also a problem with dogs, for example. Or another thing to look out for is ultra hypercoagulability. So states in which there's such an high drive for thrombosis that even with anticoagulation, you might still develop a VTE. So things to keep in mind is cancer, is again antiphospholipid syndrome, is vasculitis, and especially Behçet disease. And I recently got presented a case with a young patient who had these repeating deep vein thrombosis, who had switched so many different anticoagulations, had the maximum dose and was still developing VTE. So sometimes you need to treat the underlying vasculitis to prevent the venous thromboembolism. So sometimes anticoagulation on its own is not enough. Or there might be an anatomical reason why the patient is developing VTE, such as May-Thurner syndrome or a mechanical device. And until you resolve this anatomical reason, the VTE risk is going to persist. Also, in an approach to skin necrosis, and don't forget about it, and an approach to MAHA or a TMA. And that's all from my side.
Thank you very much, Nicola. This is such an impressive presentation, and we can all tell your love for hematology and thrombosis. So be ready. You're gonna start getting a lot of heme consults from us. So thank you very much. And yeah, thank you all for attending this session, and have a great rest of your day. Hope to see you all tomorrow. Bye-bye.